Recording in progress.
So, very good evening, everybody. We have almost been a family over the last 10 months. And some of us, me particularly, wait to make this happen. The last but one Friday of the month, 7:30 to 9. It is our own time. Novi National Allergy Asthma Bronchitis Institute, Novi Masterclass. As a brief reintroduction, Novi is engaged in clinic, research, and training since its inception in 2008, birthday 1st July, birthday of legendary Dr. Vidhan Chandra Rai, Dr. Steve. Teaching has always been an integral part of our activities, and we have very national and international standard faculties, very popular speakers. Our classes were very successful, and then we have started online. But even when we have come online, we have kept our basic character the same. So while there is a flurry of webinars around, ours is a basic classroom concept. So Novi Pulmonology Masterclass is not a webinar. It's a class. So we go to the basics. We try to go to the basics. We try to emulate the standard classroom approach, the holistic approach. So clearing the basics, establishing the concept, confusion, and probably some controversies. But you always keep in mind our target are the young would-be or just have been postgraduates. So Novi Pulmonology Masterclass, we have got many encouraging remarks from all strata of physicians, internists, pulmonologists, but our target are would-be and just postgraduate students. So we have completed 9. This is the 10th, I think. And today's topic is oxygen therapy in principle and in practice. I am Professor A.G. Ghosal, Medical Director, National Allergy Asthma Bronchitis Institute, Kolkata. And we are seeing this for last 50 years, how it has evolved over the time. What do you mean by oxygen therapy? Apparently, it's very simple, but it's a very vast topic and topics which cannot be compartmentalized. When we started in the late 70s, a very contentious topic was intermittent oxygen therapy. Those time in Viva, average student answered oxygen therapy and got just pass marks. And brilliant students said intermittent oxygen therapy, and they got very high marks. Still, I remember we had our clinician teachers. They even then objected to this concept. They actually pointed out, my teacher used to say, it is something like you are immersing a baby in the water and taking him out again. This is intermittent oxygen therapy.
Good evening, sir.
Good evening, Dhruv. Thanks for coming in time.
5 minutes delay.
Oh, no, it's okay. It's time. Thanks for coming in time. I'm coming to you. We are just starting on the introduction part. Actually, as happens in big shows, there are some introductory appearances before the big star comes. So we are just passing that time. Approach of the big star. Anyway, coming to our oxygen therapy. So, and then even in late 90s, oxygen audit had already come that time. That oxygen is probably the most misused drug in the planet. And so it has also, there were many papers at that time which came, which showed that this oxygen scarcity in hospital is actually a product of misuse of oxygen in different parts. And it proceeded like this. Then came HFNO, and again we stumbled upon these newer things. So to do justice to the topic, fortunately we have two stalwarts. Even Devraj, I say him a stalwart, I'll be coming to him, but to start with, none other than Dr. Dhruv Chaudhary. And it's a pleasure to listen when Dhruv talks. I don't want to go to the degrees of Dhruv. Dhruv does not need that. MD, DNB, DM, Senior Professor and Head, Department of Pulmonary and Critical Care, University of Health Sciences, Rotok. But what Dhruv is a great academician and great administrator. He has given a very good role in restructuring the medical education, particularly critical care and pulmonology in India. And his talk, very passionate, very emotional, so much so, sometimes he gets hurt if I go something argument against him. So this is real Dhruv, and I expect our audience, our students today will get the same pleasure of directly facing Dr. Dhruv Chaudhary. And also Devraj is there. Devraj is, once upon a time, Devraj used to stay with us. And as usual, the big star. So he went with Dhruv. He has done MD, DNB, DM, MRCP. But again, Devraj is a very ardent follower of Dhruv. So I expect, again, the luminary, the illumination, these are all he has imbibed from Dhruv. And oxygen therapy is a very big topic. We have just put some like this, but again, this will not do justice because this cannot be compartmentalized. And I have finally kept the oxygen audit at the last. I know Dhruv is an expert on that as well. So to start with, I invite Dr. Dhruv Chaudhary, his part, which will be followed by Dr. Devraj Jose, and then all together with the interaction part. Dhruv, for your information, there is an interaction part at the last half an hour. So we'll go for the interaction later. To start with, now Dr. Dhruv Chaudhary, his talk on oxygen therapy, principle and practice. Dr. Dhruv Chaudhary, please.
Thank you, sir. And it's great seeing you virtually and seeing Devraj also, but we happened to meet him just for a very short time. He came to Rohtak for my daughter's marriage. It was a pleasure. But over next 45 minutes or so, we shall be discussing about the principles and practices. And probably you will be surprised. As I discussed with you, I was talking about oxygen therapy with the same things in a different set with my colleagues of API West Bengal around about half an hour ago. And but I think what is I'm happy is from the respiratory physician's perspective, it's our bread and butter. But I enjoyed it because at least now the medicine guys has also started talking in terms of oxygen. I think that's I will call it a tectonic shift which has taken place. But nevertheless, what COVID has taught us is our inadequacies in oxygen therapy, because we all knew that oxygen we are very comfortable with. And Devraj will remember that we have been teaching oxygen therapy to our undergraduates for now more than 10 to 15 years. But I think sometimes easy availability of things also lead to disdain and disrespect. And that's what the audits told us. In fact, in our state also, we did a lot of audit. In fact, I had written to the government and government was kind enough to start that. And sir, you will be surprised at majority of the institutions, 20 to 30% oxygen wastage was a consequence of that. So So people thought it that they are being snooped, they are being tightly controlled, but I think time has come where we need to give answers. And as you have rightly said, the clinical medicine is nothing else but understanding of abnormal pathophysiology. What is normal for and what has become abnormal, and what are the factors which are responsible for causing that abnormal physiology. So by the time you take and treat the consequence of that abnormal physiology, you try to correct that abnormal or the etiology of that, so that persons are bring back to their health. That's how things they move, things are. And over next 1 hour or so, sir, I'm just going to share my screen. And just a minute. Yeah.
But it is primarily for the postgraduates, Dhruv.
Yeah. So that is why it is very important for the postgraduates to know the physiology.
Exactly.
Because what has happened is the good part of COVID has been, irrespective of all the things, people have become about the lung health. People have also become aware of the role of intensivist, and more so, with no pun intended, but it tells you the great diagnostic skills which intensivist needs to have it, and the understanding of that. So now I shall be over next. Quickly, I will be going in and oxygen therapy with the principles and practices. And I will request the students, they can interrupt me any point of time, things which are not clear. It's going to be an interactive classes. And Devraj itself can supplement, add it. And Devraj, please feel free. Now we are sitting now as an equal partner. And Dr. Ghoshal sir also, so that we talk about it, so that nuances and the points can be made clear. I hope I am, that this is my request to the all postgraduates also. Now let's look at it. Important is, we must all know, we all know that oxygen is essential for the life, especially because we all know we all are aerobic organisms. We are all aerobic lives, and their generation of ATP is important. And for the generation of ATP in mitochondria, oxygen is the key. So oxidative phosphorylation component, which was there, which cannot take place without the adequate delivery of oxygen. And we all know that the oxygen which we are getting is coming to air from us, goes to lung and blood, and there after that goes to the tissue. And you will see very interesting thing. Here it is being delivered. Here it is delivery is through the diffusion. That's how it takes place. And there has to be a gradient along which the gas flows, the water flows, and the pressure starts from the atmosphere, comes to the alveoli. From the alveoli, there is a gradient between alveolus and the artery, that is the arterial length, where it goes up to the left heart through the pulmonary veins, and then is delivered to the body. And then from there, it goes to the tissues. In the tissues, it is extracted at the level of mitochondria. But you see what is very interesting is, from 100, it drops down nearly 100 times and goes up to 1 to 2 millimeters. So this is how the whole cardiorespiratory and hematological system is working actually to deliver oxygen to the cells. From the energy perspective, it is inefficient. But from the complexity and ability and precision, there's no match to it. I think that is what is important. And once you will see continuation, it's not that the whole oxygen is extracted. Some does stay back. And that is what you see. From 100, it is 40. That is called as mixed venous blood or mixed venous oxygenation. So that's how we are seeing a sequence of events takes place. And there is a pressure gradient, there is a concentration gradient, there is a saturation gradient that is following it up. And the consequence of it is that oxygen is delivered, and at this particular level, it is extracted. Now, when you see this gradient, obviously, first and foremost, from the atmosphere to the alveoli, we look at alveolar air equation. Tomorrow, when you decide on the bedside in the intensive care units or in your patients, it is very important, especially in critical care setting. From the perspective of, it turns out to be nearly 713, 760 at the sea level, 47 is the vapor pressure. PCO2 normally, RQ, we take it up, if you see is 1.2, it is 40 and this is 0.8. This is how we look at it. And the whole PO2 is calculated in the alveolar equation. But from the bedside clinical, it is always important for us to understand and realize it. For research purposes, for practical purposes, what I've said is right. From the practical purposes, we simply take it much easier because depending upon the area which is there. So if you calculate this difference is around 700, you multiply FI2 minus PSO2, you can easily calculate on the bedside. Similarly, whenever you look at the oxygenation, you always look at it, what is the alveolar arterial gradient and what is the effect of oxygenation on it. When you give oxygen therapy, that can tell you and differentiate it, the basic pathophysiological mechanisms of hypoxemia, which takes place in the body and can help you managing, treating, upscaling, downscaling the oxygen therapy or its deliveries. So when you look at the physiology of oxygen transport, what is important is that the diffusion when takes place or the dissolution of oxygen when takes place or the dissolved oxygen, it is not sufficient enough to meet the demand of the tissue metabolism under the current atmospheric pressure. The only place this can be changed is when you give hyperbaric oxygen of 3 atmospheres and above. Then the dissolved oxygen within the plasma is good enough and you don't need hemoglobin at that point of time. But that is a theoretical conditions which you create within the lab. But short of that, you need a significant amount of oxygen and that is bound to hemoglobin. And that is what is one of the major source of storage of oxygen within the bodies. That is also the major source of transportation which is there. So RBCs have hemoglobin and that is where the oxygen stays, and that depends upon its saturation, depends upon the pressure which is there within the blood or in the plasma. That is called as partial pressure of oxygen which is there. So it is PO2 or the oxygen tension which leads to the filling of hemoglobin with the oxygen, and then the transport takes place. Therefore, the travel part is associated with cardiovascular system, which is called as cardiac output. So what you see is the blood travels up or the cardiac output is there, and while it is there, the RBCs are carrying the oxygen, which is called the oxygen content. If it is in the artery, it is called arterial oxygen content. When it is in the veins, it is called as the venous artery oxygenation content. But the driving force at both places is the partial pressure of oxygen, that is PO2 or oxygen tension. And that is also important is that you start thinking in terms of it, all right, when the blood is, when the oxygen is in the blood, how is it going to be delivered to the tissues? And there again, the transportation and the delivery depends upon another characteristic, what we call as oxygen dissociation curve. That means the RBCs are full of oxygen, but how its uptake and release depends. And as a consequence, the graph which is formed is called as oxygen dissociation curve. It has a linear component. If you see it here, I will just point the options I'm taking out. So if you will see, this is a linear section which is coming up. And there are two on the x-axis, you are seeing pure partial pressure of oxygen, and this you are looking at the oxygen content. So what you see as the oxygen partial pressure improves, the oxygen content increases. But after 60, there is a plateau which is achieved, and that's why it becomes a sigmoid or S-shaped curve. And in spite of increasing, very minimal rise in takes place. Therefore, this is called oxygen dissociation curve, and this is a consequence of the structure of the hemoglobin. Hemoglobin has got two components, alpha and beta. And with this, each component is attached with one heme molecule. And each heme molecule has a capacity to get attached to one oxygen molecule. So each molecule of hemoglobin will be attached with 4 molecules of oxygen. That's the basic thing. And that's how we calculate how much oxygen is attached with hemoglobin, and that is what decides the content of the oxygen within the RBCs. There's another thing which you are looking at P50. That means that what partial pressure 50% of hemoglobin is saturated, and this is that pressure turns out to be around about 50% saturation turns out to be around 27. And this is important, and we calculate a lot of our measurements on the basis of this. We take it up because it is at the linear curve and easily reproducible, and you can use it. Then there are 4 more components which starts coming into picture. Now, if you see, this is the red one is the normal oxygen dissociation curve. It has been shifted to the right, it has been shifted to the left. But what is very important is that once the oxygen is gone in or out, it depends, besides partial pressure of oxygen, a number of other factors. The number of other factors which are important for us to remember is, one is temperature, second is 2,3-diphosphoglycerate, that is 2-DPG, then also on HN and carbon dioxide. HN and carbon dioxide, you can take it together because this is an acid. Carbon dioxide is considered for all practical purposes an acid. It combines with water, creates a weak acid, carbonic acid. From there you have an HN bicarbonate, and then the journey of carbon dioxide starts when it gets attached as a carbinomino hemoglobin back to the lungs. Now what you see is when there is an increase in temperature, increase in 2,3-DPG levels, and there is an acidosis or hypercarbia, that again obviously the shift is to the right. That means that oxygen cannot be held too close and it is released to the tissue. If you have on the other side, you will see it is sticks to the hemoglobin and it cannot be released. So that's why you will see in alkalosis, you will find in patients of low 2-DPG and hypothermia, there is a reduced tissue release and it can cause hypoxemia at the cellular level. That is important for us to understand. It also has a clinical implications. I give you one example of 2,3-DPG. Now they are stored within the RBCs. Now in children, in neonatology, we do exchange transfusion. We do try sometimes exchange transfusion in adults also, especially methemoglobinemia, when it is more than 40% or so. So what do you find here? What we see here is that if when you store the blood, even in the general surgery, you should remember, or in the orthopedics or the other way, or in trauma, or in critical care, when blood is stored for too long a time, 2-DPG levels will go down. So when you transfuse, you are only increasing the number, but you are not increasing the oxygenation. So till for 24 to 48 hours, it is nothing else but a mechanical or a fluid overload. Till to increase occurs in 2-3-DPG levels after 2 to 3 days. Then the oxygenation stabilizes. Therefore, whenever we give massive transfusions, whenever we try to do exchange transfusions, please ensure that you have a relatively fresher blood, relatively smaller duration of stored blood. This is a practical practice point which all of us must know. Another important thing is what is called as a Bohr effect. What is it? It is again right shift to the curves so that more easily unload. This is happening at the tissue level. Practically all acid, if you see at a tissue level from practice point, is again carbon dioxide, which is produced as a part of aerobic metabolism. So this dissociation of oxygen from the hemoglobin in the presence of acid is called as Bohr effect, and the opposite of it is called as Haldane effect. And here you will see that as you go up in these cases, blue one you will see is the carbon dioxide dissociation. It is far more linear, which is there. That is very important for us to remember. And similarly, oxygen is the red saturations. Here you will see is as quickly as there will be always, like you have alveolo-arterial oxygen gradient, you have a veno-alveolar different gradient between the carbon dioxide, which is around 4 to 5 millimeters. So as it goes up, the presence of carbon dioxide moves out and it promotes oxygenation of the hemoglobin. Therefore, the reverse of Bohr effect is Haldane effect. Then the term we use is a saturation oxygen. Now that means how much hemoglobin is containing the oxygen. That's how we looked at, we have already talked about it. So oxygen saturation tells us the status of hemoglobin containing oxygen. So therefore it is important is that percentage of all available heme binding sites saturated with oxygen is the hemoglobin oxygen saturation, which we calculate. When you calculate it, when you measure it in arterial blood, it is called as oximetry, or it is through the blood invasive one you will do, and this is called as saturation arterial oxygen. The other component is when you can measure it non-invasively on the pulse basis, that is called as saturation pulse oximeter, SpO2. But remember one thing, SCO2 and SpO2 by and large will be the same, but under certain circumstances both can be different. And if there is a difference, then oxygenation saturation, we have to measure through SCO2. We cannot depend upon SpO2 because it will depend upon perfusion. It will depend upon the reduced hemoglobin content, but it cannot monitor and measure methemoglobinemia and other hemoglobinopathies. Therefore, for here, we move to another important concept in oxygen therapy is the oxygen content. So it is the total amount of oxygen which is lying there in the blood. Majority will be with the, rather predominantly it is with the RBCs, small amount in the dissolved oxygen. So you look at it, obviously, as we said, saturation tells you about the amount of oxygen which is there with the hemoglobin. So you see hemoglobin we calculate in gram per deciliter, then you multiply each hemoglobin molecule, each gram will be having 1.34 multiplied by the saturation, that will tell you how much oxygenated hemoglobin it is containing. So that's how it has been calculated. From there, and dissolved oxygen you calculate. When you see that in arterial component, this is called oxygen content, arterial, this is oxygen content, venous. So 1.3 saturation here will be, when you start looking at it, in this case is expected to be 97 to 98%. That's how we look at it. So hemoglobin will be 15 grams. In 1.3, it turns out to be 9.7. And again, the partial pressure oxygen for the purpose of calculation, you have taken 100, so it is 0.3 ml is dissolved. Out of 20 ml per deciliter, you are finding out that the total content of this 19.7, now 98% plus, is because of oxygen, which is bound with hemoglobin. Then you come to the venous oxygenation. Here you will see the saturations, they go down. The partial pressure oxygen as we low. Mixed venous partial pressure is 40 and the saturation is 70%. So you suddenly realize that venous oxygenation has gone down. So the difference between arterial oxygen content and venous oxygen content is the oxygen which has been taken by the peripheral tissue. In simple language, the content difference will give us an idea how much oxygen has been used. So roughly 5 ml has been per deciliter is being used, which we will talk little later in terms of delivery when we will add cardiac output to it, how we take it up. But remember, is all these things are total clinical parameters. You know hemoglobin, you know saturation, you know purity. So you can calculate, and if you have a center line inside, it has gone, it may not be a classical COV2, but it can closely go with that, because if it is in the right atria or the right ventricle, you can take it up and calculate the oxygen difference between the arterial and venous content. And obviously, when we talk in terms of oxygen consumption, which is important in the critical care practice for us, on the bedside, you calculate what is the cardiac output, which is Q, and then you multiply with that difference between the arterial and venous content. That's you calculate, but it is important we don't consume or include in it consumption of lumps. So this variability, depending on the clinical state, be variable, but can be on an average 5 to 18%. Then obviously the another term which is being used is an oxygen extraction rate. This tells you index of efficiency of oxygen transport. And again, extraction will depend upon utilization divided by delivery. And INCO, when you look at it, utilization we talked about between the saturation, oxygen, venous oxygenation, we are looking at it. And this, what we have simply tried to look at it, and the delivery oxygen is, we have taken away the other factor, keeping everything is constant. You look at the saturation difference between arterial minus venous divided by the arterial, and that is the normal oxygen extraction ratios. If you will see, that means if you are getting, if you really ask me, body has given you reservoir 3 to 4 times of oxygen delivery. Therefore, when you see oxygen extraction ratio has gone up, that means delivery either is poor or peripheral requirement is very high. That classically happens in stagnant hypoxemias. That can also happen in some other conditions, especially when, like in anemia, when you will see that oxygen content extraction will be much more. There can also be where it may be less than normal, as you can see it in patients of histiocytotoxic hypoxemia, as is seen in the conditions of cyanide poisoning. Same thing you can also see in dysoxia occurring in patients of sepsis. Another important thing when you start looking at in terms of causes, etc., of respiratory failure, I'm not getting into it from the oxygen perspective, is a shunt physiology. Normal shunt 2 to 3% are there within the cardiorespiratory system. But what we see is ventilation perfusion has to be adequate. But what you see when your alveolus is all perfusion, no shunt, no ventilation, it is shunt. All ventilation, no shunt, these are no perfusion, is your dead space. Shunt classical example is a severe ARDS or oxygen-resistant hypoxemia. So you can have also in massive pulmonary arteriovenous malformations can also cause this. But clinically, we see commonly with ARDS and pneumonias with lung contusions. This is commonly seen with pulmonary embolism, the dead space, or can also with the low flow states, which can be there, or there is a massive increase in PEEP physiologically when you do patients on ventilators. This can also happen. Therefore, what you see is in shunt, normally what we see in the shunt is that normally 2 to 5%, 2 to 3 is average, but not beyond 5% if it is there is a normal. So blood will come through the pulmonary arteries, it will go through the alveolus, get oxygenated and out. So however, when you see that there is no ventilation, then probably you will see that yes, the shunt is taking place. Shunt fractions you can also calculate clinically, hemodynamically. Also, it again comes up in the cardiorespiratory system. Remember one thing, heart and lung have a very close interaction. And heart and lung are in series. You have the right side of the heart, then you have the lungs, then you have the left side of the heart, and then you have the systemic circulation. So the whole circulation cascade, if you see, it is in series. Now, what you see here is what we are looking at here. We take that end capillary oxygenation is equivalent to end alveolar oxygenation. So like any other thing, when pulmonary artery goes, you have a pre-capillary, you have a capillary, the post-capillary. The post-capillary pulmonary artery pulmonary capillaries, oxygenation is considered to be surrogate equivalent that of alveolus. And that is why when we calculate the fraction, this is the content of the oxygen in the end expiratory, end capillary oxygen minus arterial oxygen content, and this is a difference between the oxygen content of the capillary and post-pulmonary capillaries minus the venous oxygenation. So the ratio of it tells us in terms of shunt fractions. And QSQ is obviously, this is the QS is the shunt through that, and total cardiac output we can calculate today non-invasively. Earlier we used to use the fixed principles, invasive method, thermodilation methods, but no longer we can now calculate clinically. And here pulmonary and capillary oxygen content, usually for this, people used to do invasive testings in terms of pulmonary capillaries, but nowadays we can calculate in terms of non-invasive managements, which can be there. And obviously this CVO2 was calculated from when we were calculating CVO2 from mixed venous content from the Swan gauge catheters or the catheters which are there in the pulmonary venous blood. Whereas CC2, which needs to be calculated, again, has been calculated from partial pressure of oxygen multiplied by the hemoglobin. And we are now on the bedside itself can calculate shunt fraction. So if you have an oxygen content of a fully oxygenated and capillary blood, you see saturation into HB into 1.3 with the same principle, 130 mm. Now mixed venous blood is 1970. With the arterial blood content, we found out that the saturation is 90%. So the net result when you calculate QT will be is simple, that you have 130 is the one you have taken 170, 97.4. That when you convert it into percentage perspective, it becomes 40%, which should not have been more than 0.02 or 0.05. So what is very important is that when you calculate shunt fractions, this is the key one, which is both in denominator as a numerator also. So that what we need to do, we presume that oxygenation is taking place adequately. Now, this is the summary of what we have done, which was published in British Medical Journal in 1998. So you should remember this by heart, that you have a dry air, then you have come a humidified air, oxygen pressure falls a bit of it, then oxygenation takes place, as I said, shunt is 2 to 3%. And from there, the oxygen arterial content is there. This is an oxygen delivery, which is roughly, your content is 200 ml per liter and the output of 5, so it is a 1 liter is being delivered. And then there is a difference between arterial venous ones, and you see mitochondrial reaching around 10.2 to 6.3. And this is where the CO2 production occurs and oxygen return. So 250 ml nearly has been used per minute, which roughly is, if you calculate, we looked at the deciliters, nights and the liters and the milliliter, and you will find it out roughly 1/4 of oxygen delivered is used, it brings back, and that's the whole concept. This is the house circle run. And this is the difference between the red and blue, is the oxygen utilization, which is, we presume, you have the same cardiac output which is there. But yes, the contents are bound to be different, and because of which that is how things are. So this brings down to the things we are looking at oxygen therapy. What is hypoxemia? We start looking at, all right, if the oxygen is not being adequately delivered to the tissue, what it leads to? It leads to hypoxemia. So that is governed by the balance between the delivery and utilization. As I said, normal output is around about 1,000 ml, and it shows cardiac output in oxygen transport. Therefore, you have to have an integrated function of heart and lung. And the third integrated function, which is a function of a cardiac content, oxygen content, is hemoglobin. So these three systems have to work together to deliver adequate amount of oxygen to the tissues. That is why when we talk of hemodynamics, it becomes important for us, or when we talk of respiratory physiology, to know cardiac vice versa. That's how it is there. So now when you look at a poor oxygen delivery, when you start looking at the tissue hypoxemia, obviously poor oxygen delivery will be, output will be low. It could be any cause of shock, which will be there. Then again, content has to be low if oxygen delivery has to be low. So anemia is an important cause of poor oxygen delivery. And similarly, for any reason, if you have a low oxygenation states, that can also cause for arterial hypoxemia for any cause if it happens. Or hemoglobinopathies, because like if you have a methemoglobinemia, it won't carry. You have a sulfhemoglobin, it will not carry. You have a carboxyhemoglobinopathy, they're not carrying adequate oxygenation. So they will all lead to significant cytotoxic or tissue hypoxemia, which will take place. Similarly, when you have inappropriate utilization, when electron transport chain goes away, like in patients of cyanide toxicity, even to that extent in sulfose poisoning, part related to the electron transport chain failure. Then you have a decreased oxygen utilization as occurs in sepsis. There is a peripheral shunting. Where mitochondria is not taking up oxygen, it just doesn't respond. That is called today as a microcirculatory mitochondrial dysfunction syndrome. Then oxygen excessive production utilization may take space requirement, and the thyrotoxicosis, Paget's disease, or it can also occur in fevers. So the question comes, how you do assess tissue hypoxia? Now, we said clinically we have realized this time in COVID is the easiest and the best way for us is to do oxygen saturation. But the gold standard continues to be arterial and oxygen saturation. And obviously, there's another important component of it. When you have everything is fine, you need to look at as a consequence of the occurrence of anaerobic metabolism, which we see in terms of serum lactate. And also, we try to find out what is happening to mixed venous oxygenation. So oxygenation is not only the arterial blood, that is the delivery, but the consequence of delivery and how the tissue is behaving is told to us by the venous oxygenation. Therefore, what is important, my dear friends, for us is to know that SpO2 will also be reduced if there is a reduced delivery of ischemia. But if somebody has a dysoxia because of sepsis where decreased utilization is there, you may find a paradoxical rise in SpO2 in early phases of sepsis. Therefore, SpO2 measure, we can only measure non-pulse oximetry, that is through the designated as SpO2, as I said. But in toxins, you will see that SpO2 becomes fixed, it doesn't change. But when you do SpO2, it is far higher. And that is called as saturation gap. That means arterial oxygen, when you monitor invasively versus pulse oximetry, which you monitor non-invasively, the gap between is more than 5% is abnormal and is a consequence of hemoglobinopathy, whether it is carboxy or whether it is methemoglobin. In co-oximetry, you can actually direct measure carboxyhemoglobin and methemoglobin. But the difference between the fixed one, if you find it up, not going up and down with oxygenation, think in terms of hemoglobinopathies. As I said, that is also the limitation of pulse oximetry. Here you will see that pulse oximetry will tell you the percentage between total oxygen versus reduced hemoglobin concentration ratios. That's what it tells you. So it is important when you're assessing and also looking at additional mechanism of hypoxemia. People have used 6-minute walk test because that further adds to ventilation perfusion defects and diffusion defects. But by and large, that is what we need to know, that limitations are there in pulse oximetry and everything depends upon the organ perfusion. Therefore, if the tissue perfusion is not adequate, that is why PI index is written, perfusion index, that is what it is called as, whether it is adequately going up or down. And secondly, if you have a nail paint, it won't pick it up. So you may have false values, and now we are realizing color of the skin also making difference. And one of the things now in the West being debated is it because pulse oximetry used across in the blacks in particular, they were not able to detect hypoxemia much early. There were some inherent defects. Now, these are the issues which can be discussed or debated. But if you have a cold, stagnant hypoxemia, pulse oximetry can be notoriously wrong. Therefore, if BPs are low, it won't pick it up. So it is important for us to remember. So other assessment becomes important for us. First and foremost is the arterial oxygen gradient, which defines with the P in terms of today the definition of ARDS. But we realize that everywhere ABG may not be possible. So we go in with a modification called as Kigali's modification. So what you do is you do pulse oximetry, you do FiO2. If it is less than 315, take it as it is a mild ARDS or mild acute lung injury. And to see also, when you're giving oxygenation therapy with HFNC or other high devices, now you can look at what is called as respiratory rate oxygenation index. You take the same Kigali modification divided by respiratory rate will give you that, yes, whether person is having adequate oxygen, because if oxygenation is adequate, this minimal respiratory failure rate has to be less. It is if your respiratory rate is far higher, that means ROX index is going to be low and the cutoff we take it up as a 4.85. And you need to give treatment, monitor it at a regular basis, but never go beyond 4 to 12 hours, depending upon the clinical condition. And alveolar arterial gradient is important for us to understand the cause of hypoxemia, which is important. And then you need to differentiate between hypoxemia and hypoxia. So your low arterial tension, which you measured, is hypoxemia. Hypoxia is the process through which hypoxemia is taking place. And these are the various classifications which are there. So most of the time, single values of no importance. Always look at the trends, how it is happening. And today we define clinically severe hypoxemia on the bedside on PO2 FiO2 ratios. If you are having a PO2 FiO2 ratios less than 150 and less than 100 is one of the severest form of hypoxemia. And these are the types of hypoxemia we talk of. Hypoxic hypoxemia, you will look at low arterial oxygen tension. You know how the low PO2 can be. It can be hypoventilation, high altitude. It can be low FiO2 in anesthetic incidents. You can have a diffusion defect, which can also contribute, but they can secondary causes, not the primary cause. And VQ mismatch is the commonest cause of hypoxemic. So if you give oxygen, it improves in all probability from the practical clinical bedside with elevated alveolar arterial oxygen gradient. You are dealing with ventilation perfusion mismatch. Pulmonary shunting, remember, like oxygen-resistant hypoxia is pulmonary shunting on the bedside. Now, hypoxic or anemic hypoxia, I already talked to you about the decreased hemoglobin levels or abnormal hemoglobinopathy. So your total oxygen content and delivery reduces. Stagnant hypoxemia occurs because of shock, hypoperfusion, or blood flow to the tissue is inadequate. That's how we look at it. Shunts could be there, decreased cardiac output, it is there. And histotoxic hypoxemia, classical example, cyanide and dysoxia. So when you look at it on the bedside, how you decide what are the causes of a differentiation between on the basis of what I'm dealing with? You look at only three things: arterial oxygen, venous oxygen. If you're getting venous oxygen, much easier to get it. So what you do it, arterial PO2, you look at content, you look at saturation, same thing. And you look at clinically whether cyanosis is present or not. In hypoxemia, hypoxemic, this thing, your arterial oxygen content, venous oxygen content, and their respective partial pressures all will be reduced and cyanosis will be present, and this is the central cyanosis. In anemia, you will not see any cyanosis. What you will see is arterial blood gases. If you do ABG PO2, arterial will be normal. But when you monitor the content, because HB is low, it will be declined. So the net result will be saturation of the venous PO2 will be far lower because of far more extraction, and oxygen content will also be low. In stagnant, everything will be normal except venous PO2 will be there. Delivery, if it is there, there's a local stasis. That's what you will see. But in histotoxic ones, which are there, you will see that venous, because the oxygen has not been used, everything goes up. So let's look at it now, the causes of clinical. Now we switch over from physiology now to the clinical bedside. Now, what are the causes of arterial hypoxemia? We all know today we should always calculate alveolar arterial oxygen gradient. When you look at the blood gases, you look at what is the pH. Obviously, one side you look at oxygen and look at alveolar arterial gradient. And when you start looking at alveolar hypoventilation, it is far more important to know, because if hypoxemia is there, is it a part of ventilatory alveolar hypoventilation per se, or there is an additional factor which is there and you need to do it. As far as the diffusion defects are concerned, that's what we saw this time. Interstitial pneumonitis was an important cause, but by and large, usually this is a secondary add-on cause. Primarily, again, it is a VQ mismatch. And shunts, what we are seeing. So if you find elevated CO2 with the normal alveolar arterial oxygen gradient, it is primary hypoventilation. If you find hypoxemia with normal PO2, then look at the oxygen incidence, or in hypoxemia pressure goes up. When you go up, then obviously the driving pressures are low. So hypoxemia is there in the cases of high altitude. So this is how we differentiate between causes of hypoxemia. You calculate alveolar artery if it is a normal. Remember, decrease FiO2. Hyperventilation, I've already talked to you. Primarily, there is no alveolar arterial gradient. These are the only two causes, but if it is there, then you look whether it responds to oxygen or not. If it corrects, it is VQ mismatch or diffusion. If it does not, it is shunt. So on the clinical bedside, it is much easier for us to find out how the oxygen, you can look at the various pathophysiological mechanism and then try to find out what is the E2 pathogenesis of that and treat it accordingly. So the indications for oxygen therapy, friends, is hypoxemia. If you are finding increased work of breathing in terms of more respiratory muscles working, you have a coronary, or you have suddenly find that the heart is working much more. If somebody has anemia and you have a myocardial ischemia, then this will be a problem. Pulmonary hypertension, which can be there. Then you can have pre-oxygenation induction and difficult intubations. You can do pre and post suctioning. Commonly, we do it in intensive care settings. Post-operative oxygenation, especially if you are having surgeries, and hyperbaric therapies for management of wounds, especially you have anaerobic infection, diabetic wounds, etc. Of carbon monoxide toxicity. All these places you know oxygen therapy. You can give it in hospital, domiciliary, and depending upon it, you can give it with the different devices. Flow of administration decides about it, not only flow, whether it's a variable or a fixed amount. High flow devices will be relatively fixed devices. Low flow devices will be non-variable devices. But what is very important is that you can practically give oxygen at any place. And there are multiple delivery devices now available. But principle remains whether you are able to give fixed oxygenation or variable oxygenation. And the chronic lung disease, it has a huge significance, and we can convert in emergency catastrophe. Now, again, then leads to oxygen generation sources. Hospital, classical, we are looking at liquid oxygen, but we are looking on-site gas systems and also compressed gas cylinders. That is what is happening. But today, additional one which has been added besides this is that we are having now industrial oxygen concentrators have come up where we are generating oxygen. Similarly, in domiciliary oxygen therapy, you can, again, the devices there. Commonly, we are depending upon oxygen concentrator. Gradually, liquid oxygen, as it expands, will take place in our ICUs. Now, this is our classical liquid oxygen plant in our institution. And this is the new PSA plant. We have 3 new plants of total capacity of 1,000 liter PM, 2 plants, and 833, another one. So practically, we can now generate our own oxygen. And this is around 10 KL liquid oxygen plant with us. These are cylinders, oxygens. Now let's look at the oxygen therapy. We are trying to look at it that oxygen therapy is, you think in terms of COPD, you keep it around 90%, whereas in other conditions, you look at 94%. And you start with most of the time with the nasal cannulas or face masks, but in COPDs, we go with Venturi masks because it gives us a fixed one, and that's how we move on. And then we are dividing these HFNC NMEs, and now we have further gone into ATMOS with invasive ventilation. So there is a sequential events in which you can go in one way, you can go the other way out, depending upon where you are working. When a person comes to me in intensive care units, obviously, these are the steps, and same thing you can have in respiratory wards. Now, there are various delivery devices which are there. If you are well aware, we will be more than happy.
COVID.
So that's how we look at it. When we mask at different flow liters, it will give you a different fixed pattern. It can take care of ventilator requirement up to 20 liters. Beyond that, then it can also be erratic. But remember one thing, nasal prongs are the commonly used for the domiciliary one. Face masks you can use in emergency, but people can have a claustrophobia feeling. And RBM you can deliver up to 90%. Commonly we are using it up, and all of you have used it now in COVID. Beyond that, I think all of you have become quite well versed with it. Now, there are the different devices which we are giving it in our intensive care units. This is a double nasal prong with a cylinder, and this is what you are saying is the mask which is there. It's a non-rebreathing mask, so be careful. CO2 can sometimes get elevated. And this is the Hudson mask, and this is a high-flow nasal cannula. That's what we are using on day-to-day basis. Now, high-flow nasal cannula has a big one which has happened, and it has become fashionable to talk about it because it can give you precise oxygen delivery, FRC, enhancement, dead space. Remember one thing, the minimum flow which is required for HFNC is 30 liters. That's what we look at. So we have been using it only when persons have been using excess muscle, otherwise we are, because they are flow guzzlers, they're oxygen guzzlers. And we realized that our parallel in COVID, that when we put more than 10 units in one of the main ICUs, practically the oxygen saturation drops. So when you use it, and that's where the concept of, we started looking at an oxygen audits, and then we realized the mistakes we have made, and we tried to cover it up. Excellent tool, but remember one thing, it is an oxygen guzzler, can hugely consume it. So it is very important because I will come to that. This is again a device of oxygen flow therapy, which we are giving it to our patients in our daycare settings. It gives you a precise oxygen delivery, no doubt about it. Room air entrainment oxygen dilution takes place. But here, there is a minimal room entrainment because we are giving it a very high flow rate. The significant thing has been development of the catheters, which are there. They may cost you 3,000 to 4,000 at the oxygen cannulas, which are there in these cases. And what is important is when you use this HFNC, inspiratory flow rates are very high. So greater delivery of oxygen. So the probability is that it will take care of your ventilatory need and requirement. 30-35 liters is a very huge requirement. And nasal flows are around 30 LPM. Beyond that, if you will do it, will be very uncomfortable. And that's what it will do. It increases functional residual capacity. And it can, because you are giving it with a high flow, it generates some amount of PEEP. And the consequence of that is FRC, which could be a great use in patients of, especially in patients of ARDS and hypoxemic respiratory failure. It also, you have a dead space. The dead space is in the airways and the nasopharynx. So it takes care of the hypo, it just washes away. So the net result is that probably the excess work which has to be done also reduces. Similarly, when you look at it between HFNC, NIV, and traditional oxygen, what we are finding in hypoxemic respiratory failure, it reduces intubation, reduces mortality. I think that is very important for us to remember. But if somebody has a CO2 elevation, NIV, there we have finished a track, DM dissertation, where we compared NIV versus HFNC in terms of acute exacerbation of obstructive pulmonary disease. We didn't find a difference, but in fact, numbers were small, but nevertheless, what we found was that CO2 washouts, CO2 never went up to that level, but we definitely found that patients are far more comfortable with NIV, and we have to switch 3 to 4 cases from HFNC to NIV. Vice versa didn't take place in acute exacerbation of COPD. So what you see in simple setting is that you have a high flow, you have inspiration, you have an expiration, you have a positive and expiratory effect, you have alveolar recruitment, dead space washout. So the net result is improvement in oxygenation, and obviously humidification is important. You don't do it, we have landed up sometimes with massive epistaxis. So I think it is important. And secondly, you need to be careful because oxygen is a drug, not a gas. And we probably somewhere there was a back of mind that high oxygenation which we used might not have even contributed to secondary lung injuries in patients of COVID in particular. So I think it can also help us in preventing intubation. It has, we already talked about positive effects, complications. As I said, epistaxis is important, and secretion blocking happening there. So I think let's move it out, and you look at, keep on assessing it. It's not that it's a panacea. So please do calculate ROX index. And if you find it up, it is more than 4.75 for simple language, easy to remember. That's how I remember it. And if it is more than that, please, it's time to switch over to invasive ventilation. So the risk of oxygen therapy, the depression, ventilation, hyperbaric oxygen, remember the formula of 12%. Oxygen, if you use 100%, you will end up within, if you use oxygen 100%, within 12 hours, you will be able to do 12%. If you're using 80%, you will be in 24 to 36 hours, you will be able to cause damage in the patients. And then if you are using 60%, it will take 72 hours and above. So that point I'm simply saying is that oxygen we consider is a gas. Yes, it is elixir of life, but elixir itself can be toxicating. Therefore, use it judiciously and try to save the oxygen. It's a precious commodity, as COVID has shown us. And with this, I think I stop short here. But remember one thing, I will be more than happy to answer your question. I've not talked about home oxygen therapy, but I thought that answer can be answered while questions will be asked. By and large, more of it is in the acute care settings, but in chronic cases, in particular COPD, please do assess blood gases. See what is the level, give them 1 to 2 liters, and then devices which you choose are important. And oxygen concentrators have become relatively cheaper now, and we should use it as quick as a method. But most important and comfortable method to deliver oxygen there is, again, nasal prods. But you need to assess when you want to prescribe long-term oxygen therapy, person should be in a stable state. Once stabilization has taken place, 6 to 8 weeks after discharge, please look at it and then take a call. Not that on the just heck of it, you prescribe it. We are prescribing it to interstitial lung disease also as a part of it. And remember one thing, oxygen is not for breathlessness. Oxygen is for hypoxemia. If breathlessness is because of hypoxemia, it will help you, but not the other way. With these remarks, thank you so much for taking an hour or so of yours. We'll be happy to answer. And sorry, Devraj, I just spoke, and now it's your turn. And Dr. Ghoshal, sir, please.
Nothing to be sorry, Dhruv, because everybody enjoys when you talk, number one. And number two, it was extensive but very focused, actually. And as we said, and I also remind you, very politely, Devraj and Dhruv also, that there is a problem of concentration and retention. So we cannot be very extensive further. Devraj, please be stick to your subject.
Sir, I think it will be better since mine is recorded and most of the topics are already covered by Sir. So if Sir just tells some briefly about oxygen audit and then we will go to the question answer session. I think that
I'll come to that. That's not a bad idea. Actually, Debraj, it's a good idea because there will be some overlap. No, but still, for the students, actually examiners ask ridiculously easy questions in the hall, even in theory, and from that they can gauge the knowledge of the student. It is not necessary that you have to go be very high flying. Very basic. Number one is, when do you give oxygen? So indications of oxygen therapy, Dhruv has covered that very well. And then they ask, you may think it's surprisingly humiliating to very brilliant students, why do you give oxygen? And so comes the physiology, how oxygen therapy works in each case, and each case is individualized. And third is the logistics part, how do you give oxygen? And then comes all the devices and other things. Now, Dhruv, as you said that alveolar arterial oxygen gradient is the important stepping stone before you divide the things of hypoxia. Can we summarize by saying that basically primary lung involvement is where arterial alveolar oxygen gradient is widened, and extrapulmonary are those where the alveolar arterial oxygen gradient remains within the normal range. Do you agree to that?
Not fully, sir. Reason is, like suppose you have a primary hyperventilation, you have obesity hyperventilation syndrome. Patient may have an hypoxemia there. They're not necessarily, because again, it is coming up because we are having hyperventilation, you are having other things. So from the practical acute care perspective, what you're saying is right. But hyperventilation, which is dominantly responsible for causing oxygenation, if that is abnormal, you will have hyperventilation. And
what? Yes.
So hypoxemia, if there is a definitive lung involvement, there I do agree, alveolar involvement and oxygen, hypoxemia is there, then alveolar arterial oxygen gradient will be high.
No, that's what I mean. Actually, you used to go by bedside communicating like this. If it is primarily, say, lung, alveolar, interstitial, something like that, alveolar arterial gradient will be increased.
Anything, sir, which is involved with the oxygenation, diffusion, and with the ventilation, or sorry, they all will be abnormal. So that is how we look at it, where we are fitting into it.
And when it is primarily hypoventilation, the alveolar arterial oxygen gradient is going to be within the normal range. Okay, that's fine. Another thing, particularly you have this high flow and low flow oxygen. Do you think it's a misnomer actually? The low flow should be called variable flow and high flow the constant flow, something like that. Will you please comment on that?
It is not that, sir. Basically, primarily it is taken care from the minute ventilation of the individual. You see, it is very important. It is not the delivery devices flows are important. So anybody who is breathing up and down has a minute ventilation at any point of time. Now, what happens is when you give with the devices, now the ventilation can go up or go down. So let's say somebody has a requirement of 5 liters and you are giving with 1 to 2 liters of a flow along with it, and for some reason it goes down, then suddenly you will see, because of constant flow which is there, which is not taken in account of the total minute ventilation, the FiO2 level suddenly go up. That's what we classically see in patients of COPD. But when the high flow there, they take care of 2 things, because along with the taking care of ventilatory requirement, they also flush the dead space. So the storage doesn't take place. So the net result is that you are able to give a constant flow of oxygen. That is why in patients of COPD, when we are giving 1 to 2 liters, or even to that extent, even with your masks also, the variation becomes so much that the flow, the FiO2 can change from, let's say, we add 1 liter of oxygen, that means we are adding 0.04% of FiO2 in the single prong or the double prongs which are there. So if I have added 4 liters, let's say I have added practically 1.6. So aapka total, it will be more than 24%, 27, 28%. But the net result will happen is that if person starts variable, let's say I presume it will be 28%, it could be 38. 6%, 40%. So the amount of oxygen which goes inside is much higher in chronic lung diseases. And the consequence is that suddenly, because it leads to alteration in ventilation perfusion. And when alteration in ventilation perfusion occurs, in chronic lung diseases in particular, suddenly the CO2 levels, they pick up. We traditionally are talking in terms of that probably there is a removal of the oxygen, what do you call it? Oxygen drive chala gaya hai. The fact is that it is the oxygen when you are giving with the alterations in these FiO2s, you have delivered much more oxygen, and the consequence, local physiology within the lung got changed, and as a result, the more oxygenation led to vasoconstriction and less amount of blood flowing. So the CO2 still stays and shoots up. Nearly 2/3 of your oxygen CO2 level got elevated as a result of that. Rest is your oxygen drive and Haldane. But looking at your thing was a question from where we started, whether a low delivery and a high flow delivery, you just take it in terms, one group of devices are able to take care of total ventilatory requirement of the patient, and one group of it is not able to take care. So the ones which are able to take care ventilatory requirement are high flow devices. One which are not able to take up, they are the low flow devices. Therefore, we need to be careful in chronic lung diseases in the second group of patients.
Okay, well taken. Now, if you don't mind, let's have Devraj over this. There, and again, I asked all the students, you can put your question in the chat box. We are now going through the questions as well. So, Devraj, so what is this COVID? Is this possible to have oxygen toxicity in COVID? Is there some sort of reperfusion injury in COVID, something like that? COVID, too much oxygen has been bad, as they hinted by Professor Dhruv, that even HFNO may have some damage, something like that.
Sir, we all know oxygen when given in high concentration, it also generates a lot of free radicals, and the free radicals are also injurious to the alveolar epithelial, that barrier, and a lot of studies have been found that in which high concentration of oxygen also, we all know oxygen toxicity less than 24 hours, 24 to 48 hours, 48 to 72 hours. Unfortunately, in the COVID, especially during the second wave, when we have a lot of the patients, and in any of the ICU, any of the H2, when you go, a patient has been put on HFNO or NIV, and suppose the patient has been put on an HFNO 70%, 80% for 5 days, 6 days, 7 days, and where the titration has not been done, when the patient could have been kept on the Venturi mask or could have been kept on low flow oxygen, unfortunately the patient have been put on. Now we are all unaware whether this could have contributed to the post-COVID fibrosis, what we are talking about, whether this giving extra amount of oxygen in excess of the requirement of the patient, and what you are talking about the reperfusion injury, whether these have been contributed. But we all know during the COVID, as the number were excess above our capacity level, so this has been done, and that's why the requirement of the oxygen audit also comes into account.
Okay, I agree. But again, Devraj, how common you see oxygen toxicity in routine ICU practice? Just take COVID apart. How common it is in routine ICU?
So just I'm telling you about my today's experience. A patient of acute exacerbation of COPD who came to the emergency just 36 hours back, just with a classical type 2 respiratory failure. Now the patient was unfortunately found to be COVID-19 RT-PCR positive, although in CT scan there was no evidence of the lung parenchymal involvement due to the COVID. Now the patient has been transferred to the COVID HDU, and from our common logistical perspective, the individuals, they put the patient on BiPAP, but they keep the patient high flow oxygen along with BiPAP. Now, when I visited the patient today, I found the patient completely drowsy. And when I did the ABG of the patient was having pH of 7.1, PCO2 of 112, and a PO2 level of 312. So this is where the importance of giving judicious oxygen lies. And sir, what you asked about the oxygen toxicity, it is very difficult to comment upon whether because we did not interpret the toxicity with, suppose we are finding a patient of ARDS. Now we will not collaborate that this has been done due to high oxygen concentration. I used to remember the days when sir used to talk us, when sir comes to a round, in morning round, whenever he used to see a patient has been put on an FiO2 of 90%, 100%, he used to scold us. Because the oxygen itself, when a patient has been put on 100%, it is very difficult to interpret whether the toxicity, how could you have been interpreted? Because the free radical, the alveolar arterial oxygen gradient, or the amount of oxygen, or the, but you can have some idea from the ventilator graphics. In high percent of patient, what is the primary cause of such high oxygen requirement? So we need to know the physiology, otherwise it will be very difficult. A patient of pulmonary embolism, if he is requiring high concentration oxygen, the physiology is completely different, where a patient with ARDS is requiring, where you need to recruit the lung. So there lies the importance of physiology, sir, but it will be very difficult to comment upon clinically whether it has been contributed due to oxygen.
We agree. So what you mean is, probably a lot is going unnoticed.
Yes.
Yes, we fully agree. But that part is very much noticeable. This precipitating type 2 respiratory failure by inadvertent too much oxygen therapy, which particularly happens in ambulance. A patient is coming, say, from 150 kilometers away in ambulance giving high oxygen, and it lands with the type 2 respiratory failure. Okay, there is a apparently simple question: in which cardiac conditions we need to go for oxygen therapy? May look very simple, very cardiac conditions. He wants to know. This is the classroom. Okay.
Yes, sir. Sir, in any of the cardiac conditions, we all know there lies an importance of cardiac output. So cardiac output is an important component of the oxygen transport mechanism. So whenever a patient is in shock, maybe due to cardiogenic shock or any kind of condition when there is a congestive cardiac failure, so if your cardiac output goes down, you need to increase the oxygen supplementation. And because if you calculate the total oxygen content, it is due to the amount of, there are two parts. One is the amount of gas which is equivalent to the PaO2. But PaO2 plays a very small part because the amount, so the amount, many a times we used to see the PaO2 is 70, but the patient is requiring oxygen. So there lies the importance of oxygen content, and which is directly related to the cardiac output. So any condition, particularly due to left ventricular diseases or when there is a left-sided heart failure, there lies the importance of the giving oxygen. And in case of right-sided heart failure, in patients of pulmonary arterial hypertension, lies the importance of long-term oxygen therapy. So I will classify it into left-sided diseases and right-sided diseases. Whenever there is any right-sided diseases, or in cases of congenital cardiac diseases where there is presence of pulmonary arterial hypertension, there lies the importance of long-term oxygen therapy. When we go by the same classification of PaO2 less than 55 or saturation less than, but in cases of left-sided heart diseases and due to left ventricular heart failure, the oxygen is always required.
Okay. Dhruv, you want to add anything on this?
You see, most of the time, like people have been using in acute MI, now the data is there. Probably it may not. If suppose anemia is there and person has an acute coronary, usually as a practice point, people have been giving it. That is one. It is a recommendation, but not there. Second is what Devraj has said, sir, any evidence of heart failure, which is there. So there you need to use it too. Three, when persons have got low arterial content, which in terms leads to anemia, and then that is precipitating to tide over tide, that point of time you may use it. But otherwise, day-to-day routine cardiac patient is not needed and required.
Okay. Devraj, now this term happy hypoxia became very popular. Actually, happy hypoxia was there even before COVID.
Yes.
So now that part taken apart. So just explain to the students what is the term, what is the meaning, and what is the limitation. Happy hypoxia. 5th year.
Yes, sir. Sir, actually, it is I will call it is a misnomer term. It should be called as silent hypoxia because the patient is unaware of the dyspnea. So there are many causes of happy hypoxia. I will not go into the details, but the most important thing is that there are there are two explanations of this silent hypoxia. The most common is that COVID acts on the brain angiotensin converting enzyme to receptors, and in cases of COVID patient, as it acts on the brain also angiotensin converting receptor, where the response is blunted, so the patient is unaware of the dyspnea. But as you already told, that silent hypoxia was there before long ago. So what happens in cases of silent hypoxia? Because of the long-standing hypoxia, the brain dyspnea. Why dyspnea is uncomfortable awareness of your own breathing. So why there is a dyspnea? Because of the two reasons. One is low PO2 and another is the high PCO2. It acts on the two receptors. So in cases of any chronic diseases, the patient, the reflexes are more prominent because of the chronic response to that hypoxia. But in cases of COVID, the time period, as it is an acute disease, so it spreads very fast. So the response, the hypoxic response is much less compared to the hypercapnic response in any of the patient. So the hypercapnia stimulates the rate of respiration much more prominently rather than the hypoxia. So there is the two reasons of silent hypoxia in COVID patients.
Dhruv, you want to add anything?
I think he has explained. Basically, it is a lack of perception of what has happened in simple words. And whether it is AC2 receptors or whether it is a CNS or whether it's because of the involvement of aortic arch and carotid bodies, that's a separate part. But we all know that yes, this had been a very big problem and nearly 1/4 patients did come to us without complaining of it. So I think he has explained beautifully.
Another question, again, students, to Debraj naturally. Everything goes through Debraj, then Dhruv. Dead space ventilation or shunt? Which is the primary factor in pulmonary embolism? Pulmonary embolism. Is it dead space ventilation or shunt?
Sir, in pulmonary embolism, no?
Yes, pulmonary embolism, hypoxia.
Yes, sir. In pulmonary embolism, there is a perfusion defect where the ventilation is normal. So I will call it as a case of dead space ventilation.
Exactly.
It's a classical example of a dead space ventilation. It's a classical example. Wasted ventilation, what you call it.
Actually, shunt should not come here. Shunt is when you have the perfusion, but you don't have the ventilation. What it happens here, you have the ventilation, but you don't have the perfusion. So shunt actually does not come here. Okay. Now, our time is very limited. And as I said, this has been particularly planned because there is a retention and concentration element, how much you can hold in one setting. So before we go further, can we go back to Professor Dhruv Chaudhary, oxygen audit, extempore, no slide.
No, there is no slide, sir. There is no slide. You see, when we talk in terms of audits, it simply means the practices, what we have been doing, are they right? Where they have gone wrong, and can we take a corrective measures? Now, this concept of oxygen audit had come up because suddenly we found out that's how it has come up in the mind of the people that during the COVID epidemic, we all had an oxygen outages, if I will say, much more in north and west, because most of the time industrial production, etc., has been much more in the south as well as in the east and the central part. But when you started looking at it, we realized that there is a lot of oxygen wastage which is going on. So we looked at trying to look at the practices of the oxygen, because most of the time people don't write how to write a prescription of an oxygen. That itself from where you started, why it is required, how much it is required, for how long it is to be given, which device to be given, we leave it to the nursing staff or we leave it to the ward boys. And suddenly you will see that person is eating, things have gone somewhere else. And sometimes you will see, I'm giving you a very small example, when you look at an oxygen regulator, which is up to 15 liters, when you take it to the top in order to improve the oxygenation, so you will be surprised how much is the oxygen used at that point. Suddenly you will see from 15 liters, it can jump up to 40 liters. We have no clue. And then we find that cylinders have gone back. Where have they gone? And similarly, when people are eating, they don't need it, or people are doing some other work in between, they will not be using it. So it has also brought us now the concept of conservative devices, which West has been there. So thirdly, when you're doing it, you have the cylinders, you have put the regulators, there is a leakage along with it. Similarly, where you have a centralized pipe supplies, there the points where you need to put the nozzles, they are leaking. When we looked at the total at my own institution, we found out that we were losing around 15 to 20% of oxygen like that. Similarly, when they did it, now you see at the peak, if I can save, let's say theoretically, to round about 20% of oxygen at any point of time, if my consumption in my hospital at the peak was 10 kL per day, 20% means I was saving 2 kL per day. That gives me more time for turnover time. And that also gives me a time to not to deny an admission to a patient who needs it, one. Secondly, then it also told us, it is very good to talk about that I have a 10 kL tank. Do my system has the capacity, because these systems have never been checked for the maximum capacities, which can be used at one point of time. Let us say I have a capacity of a system which gives me 4,000 LPM, liters per minute tak ka supply de sakta. Now I have got your high flow systems I have put into it. Now up to 2,000, let's say 2,000 a liter per minute tak ka tha. Now I have got 15 of my things working, each working on a roughly requiring 70 to 80 liter per minute of high flow system. The rest of the other things are also working. We realize that with 10, if say give 100 LPM, my 20 things should work. Hardly 15 were working. We realized there were problems with the out in the lines. They should have been, if it is 5 mm, they should have been 7 mm caliber to maintain that pressures also. You see, if you have to generate flow, you need pressures. I agree in HFNC, you need both. So you need both flow as well as oxygen. And for there, you need air. So one way of savior is that, okay, you are giving oxygen, but then you need to have a good, adequate air supply. That is a separate issue. We have some machines which are obviously within the ventilators, which were the turbine based. They were able.
Has it been made a regulation? Has it been made a regulation of oxygen audit in the hospitals?
You see, this was done by the government at that point of time. But now gradually things are coming up in terms of NABH also, and otherwise also to know in terms of auditing has to become a part and parcel of hospital management.
Regulation, yes.
Because it is a process looking at the practices, what we need to modify it and how we can improve the services. That is the idea. So oxygen audit, once we started up, it was picked up by a large number of governments. That's how it came to the Delhi government. They came to it. You will be surprised, sir. We were the first one to start the tocilizumab.
I agree. But UK is doing it since a long time. UK
has been doing it for last 15 years.
Yes, so they are doing it for a long time.
98 onwards, they started up.
They have started. So students, oxygen audit can be a definite question post-COVID era. So you have to be ready. Only knowing oxygen is good, not enough. Not to waste oxygen. That is the theme of oxygen audit. Now, Devraj, again, we are running very short.
We need to be answerable to our actions. I think that is what audit means. And that is important for us to learn.
And that will be flashed in newspapers. Okay. And then, Devraj, to a fifth year, again, just what are the present concept of home oxygen? Concept of home oxygen. Whom to? Why? Present concept, I mean, is there any change in our concept?
The concept of home oxygen.
Explain home oxygen to the students. Fifth year, 5 minutes.
Home oxygen means the patients who require oxygen at home, mainly the long-term oxygen therapy patients. Now, who are the patients in whom we used to give long-term oxygen therapy? In patients of COPD, those who have partial pressure of oxygen less than 55 or saturation less than 88%, or PO2 between 55 to 60 or saturation between to 90 with evidence of any right-sided heart failure or polycythemia or presence of congestive cardiac failure. Now, the home oxygen also, what you may ask that whether the patients of chronic asthma, whether we should give long-term oxygen therapy at home or home oxygen therapy or not. Now, many of the patients of chronic asthma at later part also develop the chronic airflow limitation and behave similarly as patients of COPD. So although there are a lot of publications or controversy regarding the long-term oxygen therapy in our day-to-day practice in patients of chronic asthma, we used to feed them similarly as the patients of COPD, and also patients of the obesity hypoventilation syndrome, and in patients of any kind of restrictive lung diseases, or in patients of the primary pulmonary arterial hypertension, or even in patients of interstitial lung disease, as we all know nowadays, and in patients of the post-COVID fibrotic lung diseases, because this is probably nowadays the most important. They will fulfill the significant proportion of the patients who require home oxygen therapy. So these are the, in a nutshell, patients who classify the requirement of home oxygen.
Okay, so we have moved from previous hour this LTOT long time. Actually, when we gone through LTOT, that time it was said that life is not prolonged, it seems to be prolonged. That was the sarcastic remark, that probably LTOT was not a bit worth. But then again, trials proved it, but latest trial also showed that marginal hypoxia, say up to 88 to 90%, does not much benefit from home oxygen therapy. But Debraj,
yes,
what is the basic theme? Just keeping the oxygen, or does it actually help in preventing hypoxic pulmonary vasoconstriction?
So the main thing is the remodeling concept, that is the hypoxic pulmonary vasoconstriction. So to improve that, this is the main reason behind the home oxygen therapy.
Dhruv, is there any serious evidence beyond this concept that this oxygen helps in preventing hypoxic pulmonary vasoconstriction?
You see, sir, there is no data which has shown any definitive evidence. COPD, we know that the evidence is there in terms of prolonging life now, besides smoking and other things.
Yes,
and
agree.
COPD is a threat. Same way, we are looking more in terms of breathlessness or dyspnea perceptions to take care of it. More than that, to looking at pulmonary vasohypoconstriction, etc. You see, it is going to help to an extent. Whether it will increase, it's a symptomatic management, sir. Whether it will improve the longevity of the life, I think it's difficult to say. Like we are seeing large number of people now today, coming a fair number, you are also seeing it, must be seeing it in post-COVID era, who are continuing to have it. So definitely dyspnea perception, it does improve. Beyond that, I think it's still premature to say anything.
Sir, another thing what I want to add, oxygen also acts as a palliative therapy in patients of lung cancer, because it reduces the work of breathing and it relieves the sense of dyspnea to a certain extent.
So you want to put that in home oxygen? I think it should. What type of home oxygen, isn't it?
Yes, sir. Yes, sir. Yes, sir.
But you see, again, for the dyspnea perception, I will rather like to use opiates, which we are not using it, rather than straight away jumping on the oxygen. I think that is, we are underutilizing, as the palliative care has already now from the toehold started having a foothold.
We are still very skeptical about it, this opioid use. I fully agree. Probably are using more oxygen rather than opioids. This is true. This is true. But again, the central theme is that oxygen is not for dyspnea. Oxygen is for hypoxia. True. And so you establish the hypoxia, you give oxygen, but then you please go for establishing the cause of the hypoxia and go for the preventive therapy. So just putting oxygen will not get us the whole story. You have to go for the preventive therapy. Why hypoxia? And you have to manage accordingly. So naturally, when Dhruv is there, nobody else can steal the limelight. But Debraj has given adequate, maintain his presence throughout the discussion. So thank you all. But before finishing, we have a custom that your message on oxygen therapy to the students. Debraj, no, Dhruv first. Your oxygen.
First, sir, I'm extremely proud of Devraj, and I will be, and I'm certain he has an extremely bright future, and this boy is good. That I should not say in front of him, but yes, he as a teacher, as a mentor, I feel very happy. That is the first part. Now let's come down to your question, to you. What is very important, sir, from this is please understand the pathophysiology. Understand the basic physiology of oxygen. Once you know that, then it will be easy for us to take clinical decisions, one. Secondly, in chronic lung disease, especially chronic respiratory disease, be careful. And third is that it is a drug. Use it responsibly. Use it like a drug. Do not cause secondary injuries and damage. And that can be a challenge sometimes.
So again, summarization before going to Devraj. So first was oxygen is not for dyspnea, it is for hypoxia. The second is oxygen is a drug, so it has a dose. And don't misuse or overuse it. These two we have already got. Devraj, anything you want to say about this oxygen therapy, students?
Sir, I will speak from a student point of view because 2 years back I was even a student. I was doing DM under SAT's guidance. So from the examination point of view, the oxygen supplementation and the oxygen therapy and the physiology of hypoxemia physiology, at least in first paper, be it in MD, be it in DM, at least 3 to 4 questions will come from this topic. And in COVID, after post-COVID, the number, even in second paper or in the advanced or recent advanced the paper, many of the questions may come. So from an examination point of view, it is extremely important.
Okay, and there is a dichotomy among us examiners actually. In theory, you will get most likely a question on alveolar arterial oxygen gradient, its importance and utilization. And post-COVID, there was happy hypoxia. Okay, but what happens in Viva, again, I tell the students, they ask surprisingly easy questions, which feel very humiliating, but very embarrassing as well. So, when do you give oxygen? Simple, apparently, but again, indications of oxygen therapy. Why do you give oxygen? Yes, coming to. Again, the basic pathophysiology, how does oxygenation helps? And third, how do you give oxygen? Here is the real hurdle, that exactly choosing the device that you particularly fit for a patient. Yes, Dhruv was telling something.
I always say one thing every time, and Devraj will vouch for it. Stick to the basics. That is the fundamental. That is the fundamental which all students should remember. That new things become very hi-fi, you need to know it, but test them, question them. And at the end of the day, when I say stick to the basics, sometimes less is more. Therefore, it is important. Part for us is we all sometimes remember the hi-fi things, but we forget the basics. Therefore, your foundation has to be strong. That is why what sir is indirectly saying looks very embarrassing questions because people get baffled by the simple question. But that is where the understanding of the subject lies. That is the key.
Okay. So thank you everybody. Professor Dhruv, Devraj, and our Lupin Logistics team. And Santosh, is anybody there from your side?
No, sir. Thank you. Thank you, everybody. Thank you, sir. And thank you.
I have a slide to share. Again, the last slide, the last part. The last part, it has to be shared.
Yes, sir.
The last one. So this is a custom from us, always to declare the next class. The next class would be on pulmonary non-tuberculous mycobacterial disease. Again, a very important topic, both in real life nowadays and in examination, theory and Viva. Thanks everybody again, Dhruv, Devraj, team, and have a very good evening. Thank you.
Same
thank
good
you,
evening to all of you. And
thank you all the participants.
Yes, thanks all the audiences, our students who have interacted and keep this on alive. And it is going popular every day. Thank you all.
Thank you, sir. Tim, you can stop the live session now.
Recording stopped.